Hi everyone, welcome to the Sign Ask the Neurologist podcast. My name is Sahdev Baweja. I am one of the board members of the Sign Club. Today I have the pleasure of interviewing Dr. Gutstein. He is a neurologist and been on the board of NYMC since 2005. Dr. Gutstein, thank you for your time.
You're welcome. I'm board certified. I'm not on the board of New York Medical College.
Sorry.
On the clinical staff.
Um, could you describe your path to becoming a neurologist?
Um, sure. I'll give you the very abbreviated version, and then I can expand it as if you want. So I graduated Johns Hopkins in 1977. I did an internship in the University of Maryland Hospital in Baltimore from 1977 to 78, a 3-year residency in neurology at New York Hospital Cornell in Manhattan. And then I basically have had 3 careers in the field of neurology. The first career was essentially a hospitalist at St. Barnabas Hospital in the Bronx, which was a community hospital. It was affiliated with New York Hospital Cornell. And it was, as I said, a community hospital, not a tertiary care center at all. So I stayed there roughly full-time for about 15 years. And then I sort of got tired of night call and seizures, strokes, head trauma, things of that nature. So I transitioned to an office practice, which I started with someone else in the Bronx also, and kept that roughly about another 10, 12 years until 2005. And in 2005, transitioned out of the Bronx and then relocated back to Manhattan. I left the Bronx, the office practice, because then I pretty much got tired of headache, neck, and back pain. That's what it devolved to. So I wanted to do something else, and I wound up apprenticing at NYU Multiple Sclerosis Care Center with a physician who founded it. He needed someone part-time, and I was available. So we worked out an agreement, and I stayed at the NYU MS Center until about the end of 2018. When I relocated back to Manhattan, I also started my association with New York Medical College at Metropolitan Hospital because I wanted to see people without MS. So I basically volunteered 1 day a week in the neuro clinic at Metropolitan under the guidance of Dr. Barbara Capel, who since is retired. But I've stayed on at Metropolitan, basically teaching medical students and going over cases essentially. And then in 2005 also, I opened up a small office, or sublet a small office for neurology across from Macy's. So I kept those 3 things going until the pandemic, and then gave up NYU because my boss died and the new regime came in, and I gave up the office because of the pandemic, essentially. So now I do what I call professor's rounds at Metropolitan Hospital, a couple of 1 to 2 days a week. And in addition, for the last 30 some odd years, I've done forensic neurology having to do with medical legal matters, both for plaintiff and defense, which has been really interesting. And any third-year medical student who's been rotating through Metropolitan knows when we have professors' rounds, I will frequently use examples of medical malpractice cases that I've come across to highlight certain important points, which I think are quite memorable, let's put it that way. So that in a nutshell outlines 45 years of neurology.
It's quite an interesting path you've had. What led you to wanting to pursue neurology as a specialty?
Well, in medical school, they encouraged us to do some sort of research. So I got involved with a postgraduate fellow in MS, who turned out to be working in the lab of the director of neurology at Hopkins at the time, named Guy McCann. So that was my first introduction to neurology, and I sort of got taken under his wing a little bit and opened my eyes to the field. And my thinking at the time was the following. I knew I didn't want a surgical specialty because I didn't want the lifestyle and I don't like blood. So I knew that was not going to be working for me. But I knew I wanted a subspecialty that was open to other specialties that treated young people, old people, men and women. And I thought at the time that neurology was on the cusp of where cardiology had gone, meaning new areas of diagnosis, new areas of treatment. So those were among the features which led me to go into neurology at the time. So important mentors and certain lifestyle considerations.
And do you, if you could touch, because you mentioned, do you think that neurology has gone towards that new diagnoses, new treatments that you were hoping for?
It's interesting that I had a medical school reunion not too long ago. We were discussing this, and all the fields had certain conditions or areas where no progress has been made. And in neurology, I'll just offer things like neurodegenerative diseases, even Alzheimer's disease. Very little has been accomplished practically. Dizziness, the same treatment we used for dizziness in 1977 is the same treatment now. But in other fields, dramatic improvement. Obviously, MRI is revolutionary. But in my field of MS, in the 15 years I was in the MS center, we went from modest treatments of the interferons to tremendous treatments with the monoclonal antibodies, the oral agents. So the answer is yes and no. But the progress in some areas has been astounding. And again, MS would be an example of that, and even vascular neurology would be an example of that. And then I guess general neurology for earlier diagnosis because of MRIs.
Okay. And I know you've had, as you called it, 3 different careers in neurology, but would you say, would be the conditions you treat across the board or still treat today?
Well, when I was a hospitalist, it was most was inpatient neurology, and the Bronx at the time, it was a lot of neurology due to poverty, drug abuse, lack of resources. So we saw some very unfortunate things that came through. And again, it got somewhat frustrating seeing the same people coming in, seizure, stroke, head trauma, drug abuse, alcohol abuse, etc. So I needed a change, as I mentioned, and office practice was rewarding, but then the logistics of running an office and the routine of seeing the conditions I said, headache, neck, and back pain, sort of led me to consider other areas. And that's what's good about neuro. There are many opportunities within the field that one can pursue with reasonable satisfaction. Some people I know have stayed in the same lane for their whole career. I know people have changed lanes more frequently than I have. But the point is they've used their background in neurology and their training and their general education in medicine to go whether into industry, research, international medicine, startups in various places, to their delight and in many cases to their reward. So I felt I didn't have to be stuck in an area that I was getting, if not bored, a little bit numb to. So I was happy to do these things. And each one of them were rewarding in its own way, I must say.
Could you also touch a little bit about the forensic neurology you said you do now?
Yeah, that's been sort of a lucky strike extra because I found it, as I said, very interesting across the board. These are cases from routine trip and falls, car accidents, work accidents, ceiling accidents, wrongful death accidents, conscious pain and suffering, issues which we can think about, but may not delve into them into the level that one needs to delve into to be in the medical legal sphere. The malpractice cases are, I hate to use the word great, but they're very instructive because they're usually good doctors, well-trained, and for whatever reason, there's a commission or an omission that leads to a poor outcome. And when I go through these records, I say to myself, I want to hit the person and say, how could you have done that? You were right there, but you were led down the wrong path, and the writing was on the wall. All you had to do is keep an open mind, or do something simple, and the outcome could have been significantly different. And I learned a lot about these cases. I learned a lot about malpractice on these cases, and I use them regularly as examples of when I'm talking about stroke, when I'm talking about back pain, when I'm talking about acute onset headache. And I find that the students and the residents, seem to perk up when I use a real life case and to illustrate certain concepts that we're all taught, but somehow we get pushed in the back from our day-to-day activities, and we need a wake-up call every once in a while, and these cases provide it. So I find them very useful from a number of different points of view, and I enjoy the give and take with the lawyers. You have to defend your position, and you have to know how to present a case or position to promote your particular side of a case. And all these cases have two sides, and knowing that it becomes a challenge to represent your side properly. Let's put it that way.
Definitely. Could you talk a little bit about how your work-life balance or your day-to-day has changed throughout your time as a neurologist? Like what a typical week in life used to be for you as you progressed in your field?
Sure. Well, as I said, one of the reasons I picked this field, as I said, I didn't want the lifestyle of a surgeon, and I knew that it might be more glamorous, more remunerative, et cetera, but it wasn't for me. So, I knew what some of my requirements were, so that was important. And then when I started at Barnabas, I was on call, 1 week straight, days and nights and weekends, which at the beginning was sort of exciting. And I chose an area where I was, if not the boss, almost the boss. So I was it. So I had to make the decisions, and I didn't have to get permission or chat with anybody else. And for better or for worse, I actually enjoyed that. But that over time became some of a lifestyle challenge, because being on call 26 weeks a year, seven days a week for 10 to 15 years got to be a challenge as I got older and family matters came in, et cetera, et cetera. So, I changed into the office practice, which turned out from a lifestyle point of view was very nice. I was able to, again, control my destiny to in a certain way. And same thing with NYU. For the first 13 years or so, there was no night call, and I was surrounded by very bright, ambitious, younger people than me. So they were willing to take up the night call responsibilities. And then when that became burdensome for me, I decided, the work-life balance was in the direction of life, less work. So I went in that direction. So I've been fortunate to be able to maneuver to get to places where I've been comfortable and have a decent work-life balance. And I have other friends in the field who managed to do the same, whether they, again, went into industry, government, pharmaceuticals, startups, leveraging their experience and their background to do other things that they may not have thought about when they started in this field.
Definitely. What advice would you have for someone who would like to be a neurologist?
I think you sort of need to love what you do, and you need to be able to be somewhat flexible in what you're doing, because life and business opportunities will present and change over time, and you have to be able to pivot. I think that's important, and I think it's also important, if you can, to develop some sort of subspecialty, whether officially or unofficially, or an area of interest that people come to you to look at for your expertise. I know when I was in the MS Care Center, I really enjoyed being the MS person. Um, and that gave me a great deal of satisfaction. Forensic neurology, again, also provided this extra area of expertise that not everybody else had or wanted. So that was also quite, fruitful and enjoyable. So I think you have to have that willingness to consider other opportunities and take advantage of them, when they present themselves, or pursue. Let's put it that way.
Definitely. What do you feel is the biggest concern facing the field of neurology today?
I don't know if it's a concern, but I think in general, we were just talking about this the other day with some medical students who are leaving. I said, probably going in the future, not too long, I think the doctors' offices and clinics will be obsolete. Everything will be done remotely, like we're doing now. We do remote banking, we do remote shopping, we do remote learning, we do remote praying. So at some point, we'll probably have an MRI on our iPhone. It'll go back to Google. It'll compare the images to 10 million images across the world. It'll come up with a differential diagnosis. They'll send it to Microsoft AI, and AI will come up with a treatment plan, and the treatment plan will then go to Amazon Pharmacy, and Amazon Pharmacy will give you a personalized therapeutic approach, or send you to the top people in your neighborhood, your community, your state, your city, or your country. And maybe there will be United Health or Mayo Clinic or some tertiary center sort of overseeing this in some way, shape, or form. But I think there's going to be great changes in the field in general, and the neurology will be part of that. This idea that an individual comes to a differential diagnosis and is supposed to be up to date on all the literature in that area and institute a diagnostic plan I think is going to be somewhat antiquated going forward.
You sort of touched on it at the end of that question, but what do you think will change in neurology in the next 15, 20 years in terms of potential treatments or anything?
Yeah, I mean, we're seeing it now, artificial intelligence, big data, evaluating patient information, comparing it to millions of gigabytes or terabytes. Personalized medicine, where instead of choosing a drug based on a method, a mode of action, you'll have a particular patient with a particular condition, and MS, you'll give a B cell treatment, a T cell treatment, a aquaphor 4 treatment, or no treatment. You'll be able to personalize treatment in individuals, as opposed to doing one treatment, so to speak, fits everybody, which I think will be good, obviously. But who would have thought, when I was in your situation, MS was diagnosis and adiosis. You can make a diagnosis after people have already been in a wheelchair or a walker, but you couldn't do anything about it anyway. Now you make a diagnosis of MS before you even have MS, because the MRI shows findings of radiological isolated syndrome, and then they come down with the clinical picture. So these are tremendous advances just in the last 15 years that I've seen, and I imagine the next 15 years will produce similar advances in other areas of neuro. I hope including ALS and seizures and Alzheimer's disease, things of that nature. And I think it will. I think it will.
Okay, and for our final question, we like to ask everyone, what is your favorite part of the brain or CNS, and why?
I would say the amygdala, because I don't know what it does. I've never seen any condition that I've been able to come across. That an amygdalopathy, but I love the name amygdala, and I'm hoping maybe at some point it may unlock the secret of some of the things we talked about. So there's something I have an affinity for the amygdala.
Very fair. Thank you so much for your time, Dr. Gustin. We really appreciate it.
Sure, happy to do it. Good luck to you.